Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick, and I'm a physical therapist focused on improving care for patients with limb loss and limb difference. In this episode, we're exploring an important and complex topic in rehabilitation: disparities and outcomes among individuals living with limb loss and limb difference. While advances in prosthetic technology and rehabilitation continue to improve opportunities for recovery, not every patient experiences the same outcomes or even access to care. Research continues to show that social determinants of health can significantly influence functional recovery, participation, and quality of life after amputation. As rehabilitation professionals, physical therapists are uniquely positioned to recognize barriers, advocate for equitable care, and help patients navigate challenges that extend well beyond physical impairments. Understanding disparities in limb loss care is critical if we hope to improve outcomes for all the individuals we serve. My guest today is Dr. Sheila Clemens, who has explored these topics extensively in practice and in research. Sheila serves as assistant professor in the Department of Physical Therapy at the University of Kentucky and is a research scientist at the Lexington VA Medical Center. In the Doctor of Physical Therapy program, she teaches amputation rehabilitation and prosthetics and evidence-informed practice. Her research focuses on examining factors associated with optimal outcomes after lower limb amputation. Sheila, thanks for being here.
Thank you so much for the invite.
Absolutely. I want to kind of hear a little bit about your background. I know your first start was not necessarily in the research. You had this kind of practice background. So kind of tell us about this journey that you've been on to kind of get into this topic of health disparities.
Sure. Yeah, I was a clinician for a long time before I went back to academia. So I practiced clinically for 19 years. And the more I've been in academia, the more I realize I was definitely on the later end of the spectrum before deciding to go back to do a PhD. So I've seen a lot of different patient populations. I really did start to focus on the limb loss population probably about 10 years into my practice. So for the last 10 years of my clinical practice, I really focused on treating patients with amputations. And I've always worked in more inner city type settings. So always at large hospital systems in either inpatient or outpatient. So I always had a really diverse patient population and just would learn things anecdotally along the way as a clinician, like I think we all do. And once I decided to go back to do my PhD, I felt that I was gaining the tools to eventually be able to really look at what I wanted to look at with these folks, which is what things contribute to poor outcomes. We all know that certain people do better than others, and we didn't know a lot about factors that went into that. And I think even as a PT student, I was interested in this kind of thing, but never really got a chance to examine it until later in my career, and that's where we're at right now. And the more I study, the more questions I have, and the more I know that we need to learn about different outcomes and different populations of people with limb loss.
Very cool. Yeah, it's quite a journey that you've been on. And it's interesting having especially gone from more larger centers. As you kind of mentioned, it's a very diverse patient population, people coming at it from different walks of life, maybe even particularly maybe like complex cases coming from different parts of the broader region too, I could imagine.
Yes. Yeah.
So good.
I was just going to say, and unique to Kentucky here, unlike other states that I've lived in both Michigan and Florida, is Kentucky is considered a rural state. And so I'm really getting the chance now to start examining some of these factors, not only social determinants of health based on income, but also based on geography, which is really kind of exciting.
Yeah. I think the word of the podcast is disparities. I think there's probably some other phrases we can put towards that. I think that can mean a lot of different things. So in terms of like your definition of that, or kind of even expanding into like other kind of verbiage that you would use, what does that mean to you?
So disparities in general, I think, means that there are, and this is the term I've been using in place of disparities, unexplained variability in outcomes. So we know, just being clinicians, and we know from some of the research that certain patient populations across the board, not just people with amputations, have poor outcomes. And what factors into those poor outcomes? I think knowing that there's biological, psychological, and social factors that play into all of these things. And in certain populations, we know more about those things. But in the amputee population, we don't know a lot about a lot of those different variables. And so why does one group of folks do better than others? And that's really kind of like at the heart of what I'm trying to look at. And in my research in particular, and I know we're going to talk more about this, but I study people who are prosthetic limb users at this point, meaning they all have insurance to get prostheses, and they all have access to prosthetic care and rehabilitation. Yet we're still seeing these pretty big disparities among these folks. And we just want to find out more about why.
I think that's extremely telling, and especially, as you're mentioning, folks who do have prosthetics is already probably selected for quite a few attributes already as it is. I think, was it a couple years ago, the GAO report on limb loss and everything, it was kind of looking at, I think, 2016 data, if I'm not mistaken, that was looking, I think, only about 40% of people actually even received a prosthetic in the first place.
Yeah. And I think, the literature is variable. I mean, it runs anywhere from like 40% to where if you look at the VA population, you're running 80 to 90%. However, the VA population is unique in that all veterans, male, female, everybody has equal access to prosthetic care. Yet there is a significant amount of research that's been done in the last few years that has used VA data that has also found disparities in rates of prescription, in rates of abandonment, and in amputation level. And this is within the VA population. These men and women have purported equal access to care. Now, some of that is geographical, where we're seeing that areas of the South, up here in Kentucky, based on race, based on amputation level, but there's definitely disparities happening within even the population like the VA, which is a closed, pretty organized healthcare system.
I was curious, before we kind of dive into some of your works here, we kind of mentioned earlier sort of this like kind of biopsychosocial sort of model. I was wondering if, just kind of like to kind of give an overview, could you give some examples of kind of each things that would fit in there? Some more of the biological, some of the psychological, some of the social things, just so we kind of have like a broad understanding.
Yes, for sure. So I'm going to go back to like 2020 when I first started thinking about getting into this type of research. It's pretty well documented that amputation rates in people of color, so people who identify as Black race, Hispanic ethnicity, Native American heritage, they have 2 to 4 times greater rates of amputation. Now, we are talking pretty specifically about the dysvascular amputee population, so people who've lost their limbs due to diabetes or peripheral vascular disease. So we know that those particular populations also have higher rates of diabetes and of peripheral vascular disease or peripheral arterial disease. So looking at that as more of like a biological type factor, the disease process, things like blood markers, mitochondrial dysfunction, things that are associated with those diseases in particular. So that's more of what we're looking at as a biological factor. Also, gender, sex, male or female, can be considered a biological variable. And it certainly has been a factor in my research and in a lot of different populations where we see differences in men and women. And I'm going to use that term right now as we're talking about sex determined at birth. So we say female women, we say male men. And so those would be our biological factors. Your psychological factors would be things like self-efficacy, things like social support, or instrumental support. Um, uh, you know, access to care could be, it could be social, it could be psychological. There's a lot of overlap when we start getting into psychosocial variables and the different things that can influence them. And certainly social variables are things like transportation, healthcare coordination, implicit bias of practitioners. There's just an endless sort of list of different things that it could be involved. But those are kind of the general ones that I look at.
Yeah, that's great synopsis. And I think, especially the note about the psychosocial issues kind of being very interrelated, because I think of like even like the idea of like isolation, for example, that could be
Yes.
almost like geographic, that could be self-imposed, depending on just their general thoughts on things and
Right.
a whole number of other factors. But yeah, excellent. Thank you.
Yes.
Um, let's go ahead and dive into. So I'm going to kind of go first. We'll kind of go into different papers of yours. So let's kind of start off with this one. This was published in. Let's see here. Is it Disability Rehabilitation, if I'm not mistaken? And this is disparities in functional recovery after dysvascular lower limb amputation are associated with employment status and self-efficacy. The name kind of gives away what we're talking about, but
Yes.
kind of give the
Yeah.
rundown. What did you all find with this?
Yeah. So we did this study to look at, it kind of stemmed from, all right, we know that there are disparities in amputation rates in based on race. We knew that. What we didn't know was, do these disparities carry over after amputation into recovery? Nobody had looked at it. And so we wrote a grant back in 2020, and it got funded right before COVID, which was great. So we had to get ourselves into a clinic population of people who are generally pretty sick to begin with during a worldwide pandemic. But we were able to do it, and we were able to collect a lot of really great data. So that was kind of the impetus for this research, was taking a look at, do disparities carry over? And we were looking specifically at racial disparities. However, we ended up finding other things that were associated with poor outcomes, employment being a big one, and self-efficacy actually being one of the largest factors when we went to look at who had better mobility outcomes. And when I'm talking about outcomes, we specifically were really focused on mobility and on activity participation. So those were sort of our quality of life outcome was activity participation, and then we had our mobility outcome. And so what was unique about these studies was that we actually did performance-based measures. So we measured in person the timed up and go test, the 2-minute walk test. And then we also did some self-report measures as well. That was really the first research to ever purposively try to look at disparities and use performance-based outcome measures. And so what we found with that particular article was that the majority of our folks were not employed full-time. And I think that's not really a surprise to anybody who works with the limb loss population. I think we were running at 70 to 80%. And we categorized them as not employed full-time. So they were full-time or they weren't. And we found that people who were employed full-time did significantly better on their walking tests and on all the outcome measures. And so employment, that was something we knew from the previous literature, that people with better mobility tend to go back to work. But what this looked at was, if you're working, does that contribute to better mobility? So we sort of flipped it. And that's what we found, is that if you were working, and this was in a dysvascular population, so we didn't include any traumatic amputees with this, was that if you were working full-time, you would do significantly better on your outcome measures. And in particular with self-efficacy, we actually, when we ran our statistics, if we ran self-efficacy and working in the model at the same time, self-efficacy just blew all our other factors away. including working. So we split the model to take a look at it. Self-efficacy is a huge driver of recovery after amputation. And that was one of the first times I think that we had really looked at it, that somebody had looked at it more in depth, and we're continuing to look at it in our studies.
Yeah, I think self-efficacy is something that I think almost as a clinician treating this patient population, you kind of sense it almost implicitly a little bit. I like that you had this ability to be able to kind of categorize it and to qualify it a little bit and to be able to see its impact on things.
Yeah.
I'm even thinking on patients that I had in the clinic today and the difference in that, and honestly, the outcomes that have come as a result of that too.
Yeah.
I still think it's really fascinating that to be able to see that work had like impact towards it. Cause I think it makes it, I think we could sort of guess and understand that, if somebody was returning back to work, oh, they're probably a little more mobile, but for that to actually have an impact towards the kind of their outcomes, I think is really neat.
And self-efficacy is really this sort of broad, complex construct. And there's a lot of things that play into it. I mean, actually working can contribute to self-efficacy. Things like social support, income, education level. There's a lot of different things that contribute to self-efficacy itself. But we know from my work that self-efficacy is really a driver of how well they're going to do using their prosthesis afterward. What we don't know is how to exactly intervene.
I think awareness unto itself is already extremely important. And I think being able to advocate for a patient, to meet them where they are, or perhaps even to, I guess, kind of be present with them. I had a conversation in an earlier podcast episode where we were kind of talking a little bit about working with like rehabilitation psychologists to kind of help in that process of processing what has happened, the motivational aspects, and all these kinds of things. So I think seeing that impact and maybe even being able to bring that to a patient could potentially be something too.
Yeah, I think that, there are self-efficacy interventions that have been explored and implemented in other populations. What we haven't seen is, how it could be implemented in our patient population in particular, and future studies. That's pretty much how we're going to find out how it affects things.
Let's kind of dive over to the other paper that we're kind of talking about here. So this is Association of Race, Ethnicity, and Gender to Disparities in Functional Recovery and Social Health Following Major Lower Limb Amputation, a cross-sectional pilot study. This was in the Archives of Physical Medicine and Rehabilitation. So kind of tell us a little bit about, is this related work? Was this kind of like all in the same?
Yes, all the same study.
Okay, very cool.
Yeah, and so really, this was kind of the heart of the study, was this one in particular. And I think in that paper, we have a lot more data now, but we ended up having 56 individuals, I think, in that paper, which was a decent size for a paper with people with amputations. And we collected it all again in a year during COVID. So I'm pretty happy with that. But essentially what we thought was happening, we finally put numbers to, was that white men were outperforming men of color, white women, and women of color. And I think in our groups, weren't big, but we've found statistical significance. And this has really been the foundation for the rest of my work since then and up until today, when I started another study and enrolled another participant this morning. It was confirming in our mind, but disheartening to know that what we thought was happening, really is happening. And that women of color, despite being our youngest group, was doing the worst. And so really looking at that intersection of being multi-marginalized, being Black or Hispanic, being a woman, and having a disability, and seeing how that is affecting these women, despite the fact that they're actually significantly younger than white men. And so that was really kind of the heart of the findings of that paper.
Were the kind of impacts of these social determinants, et cetera, were they additive? Like if, like for example, I don't know if this was done statistically analysis, but like, if you're a woman, you had a certain amount of risk, but if you also were a woman of color, that you had an increased risk based on top of that.
Yeah, in this paper in particular, we didn't have enough power to really see that. And when we decided to look at the intersection of race and gender, we didn't find a significant interaction between the two. But I will tell you that in one of my recent studies, which we should be probably getting ready to publish on this summer, and in some of my colleagues' studies, we both found, and these studies were both in Black persons with dysvascular amputation, that women were doing worse, and women from very high area deprivation areas, meaning that they were either poor areas or areas of high crime, things like that, were doing worse than anybody else. So it is some evidence that there is this compounding of these biopsychosocial variables, but we don't have enough information right now to really come to huge conclusions, but the evidence is definitely is starting to expose itself.
Yeah, absolutely fascinating. I'm looking forward to seeing more of that. That's awesome.
Mm.
But yeah, I can only imagine getting the recruitment and getting the power towards that. I was thinking even like the numbers that you had for the studies you've already done, it's already pretty good, but it is hard. I can only imagine.
Yeah.
I'm kind of curious, beyond that work, are there other factors that have like piqued your curiosity? As you mentioned earlier, it's like each question answered is like brings on the next question. And I think that's kind of the natural heart of the researcher. What's kind of on your mind? What's next?
I think because we haven't really, I'm actually in the process, we're going to write a pretty large study and submit it to the NIH later this year. Fingers crossed that it, at least will get discussed. We really want to get more information, but really I want to dive deeper into some of these potentially biological factors that haven't been looked at in people with amputations yet. I'm lucky here at the University of Kentucky that I've got some very smart, very well-established researchers who look at things like mitochondrial dysfunction, that look at blood markers. And so I'm kind of excited to take a look at not only continuing to look at these psychosocial variables, but also to take a look at some of these biological factors, which actually are very modifiable, meaning that if we can identify something that is malfunctioning or can be treated with either a medication or with aerobic exercise and actually change a blood marker or change something that we're looking at in the serum. I think that that's kind of exciting because as PTs, that's kind of in our DNA. We want to be able to make change in our patients, but we need the variables. We need to know what makes change. And so I think adding this extra piece in there gives a real medical aspect to it. So if we know that there is certain kind of dysfunction in the mitochondria, we actually can treat that with certain kinds of exercises, with certain kinds of supplements, with certain kinds of medications. And will that help our patients' outcomes? That's one area I think that I never thought I'd really look at. I never thought looking at mitochondrial dysfunction would be something that I'd ever do. Thank goodness I have very smart people around me that will help do that. But then also looking at this aspect of this geography, this unique state that I live in. Some of my colleagues live in rural states, and really trying to capture that population that's really never been looked at. People who are living in a rural location and really trying to find out more about their lived experiences. So those are probably the two things I'm excited about to look at in the near future here.
Yeah, I think access in terms of like rural things, kind of going back to that GAO report, that was one thing that they specifically noted about, and kind of across representative organizations, both representing kind of like rehabilitation professionals and especially patients as well.
Yeah.
I want you to kind of switch over and put on the clinician hat here.
Yep.
So let's say, you're talking to a physical therapist and, has read this and is like, yeah, I want to make a change. I want to kind of assess this with my patient. So let's kind of talk about that assessment. You know, how could a physical therapist in the clinic start asking about these kinds of things? What kind of tools might they use to just be aware of some of these factors?
Yeah, I think that's a great question. And anytime we can get a pearl to a clinician is a good day. I in For my research, I use standardized outcome measures. So when we want to look at self-efficacy, I use the Promise 8 question short form. Oh, I'm going to remember the title: Managing Chronic Conditions or Chronic Conditions, Managing Daily Activities, something like that, but it's a promise measure. And that's the one we've been using. So I would say, it's an 8 question measure. It will take your patient 1 minute or 2 minutes to fill it out. If that's something that you're looking at trying to affect in your patients, activity participation, being able to just hand them a couple of outcome measures while they're in the waiting room, and get some of that information, and then to monitor that change over time, that's a good way to measure it. As for actually trying to implement change in your patient and trying to treat them and trying to improve self-efficacy, we haven't studied that yet in the amputee population, but certainly in other populations, the things that we do on an everyday basis: mutual goal setting, connecting them with peers, peer-to-peer modeling, talking to them about what's their social network like, and finding out what kind of resources can I help get to this patient if they are lacking it. Just this morning, when I had my study participant, she's struggling with her mental health. And so as a clinician, sometimes we don't have those resources at our fingertips. And so I reached out and, I'm going to try to find out somebody that she can go talk to. And I think that's, as a physical therapist, that's kind of what we do. But as for measuring it, those outcome measures are a good way to do it. And it's quick.
Yeah, I was actually going to say we use that particular promise measure where I work, and we have it kind of embedded almost like in like electronic record too. So it is actually sent out. I can attest to it. It's
Perfect.
very simple, very easy. And I had it written down. It is the Promise Ability to Participate in Social Roles and Activities Survey.
Yes. Yes. And then they have the
No short
self-efficacy
title.
one. So
Yes.
I will do both of those.
Perfect.
Yes.
Yeah. Yeah. Those are great ones.
Yeah.
Yeah, I'm kind of curious. Are there some other questions that you may like kind of ask? Like, I mean, in terms of like social history, et cetera, on top of those things?
Yeah, I mean, you certainly want to find out if they've got, we always ask about what's your house like? How many stairs do you have to get in? But you might want to ask things probably typical of what the questions we get when we go to a primary care physician nowadays. Have you been struggling to pay your bills over the last month? Have you had to miss appointments because of lack of transportation? Have you had to skip or not take doses of your medication because you were afraid you couldn't afford the next dose? So trying to we have to be careful as PTs also to not overstep what is our boundary. We're not psychologists, we're not therapists, we're not social workers, but can we ask enough questions to know how to make the referral, and get those folks the help that they need? But I want to say we do a pretty good job of asking them, especially if they're wearing a prosthetic limb. When was the last time you were at the prosthetist? If they're diabetic, when was the last time you were at your podiatrist? I got the answer I did not want to hear this morning when I asked that question, which was, oh, I don't remember. So trying to help folks Care coordination is a big deal with these folks. They're, especially if they've lost their limb due to diabetes or vascular disease. So again, I think every day we struggle a little bit to try to be care coordinators for our patients, but we can only do so much. Just asking the questions to make the referral is probably a really important step, I think.
For sure. I'm curious, as having worked in a more urban kind of setting, larger like hospital center kind of setting, how did that play out in your particular context? Like if like you had a patient come in and maybe you might have been the person who identified some of these issues. What were kind of the steps that you were taking for that?
Yeah. Yeah. I think I worked really closely, with the prosthetist. So if I saw somebody come in whose leg was clearly not working for them, either because it was being neglected or they were unsure how to get something fixed. They didn't know, they weren't sure about how, something was going. I would definitely contact the prosthetist. I also would reach out to physicians. So I think that multidisciplinary care is really important. And I don't really have a problem asking anybody for anything. The worst somebody can say to me is no. So I do not hesitate to call a physician's office if I need to really try to make that team to surround the patient that they need. And so that's kind of what I did. I've been lucky enough to always work somewhere where I had physiatrists who were willing to join me in doing clinics monthly. And so that was a really nice way with the prosthetist and a physiatrist and PTs and OTs to be all together. And so establishing an amputee, monthly amputee clinic, I think is a great way for a clinician to try to coordinate that care to the best of our abilities. And that's what I try to do. Again, the worst they can say is no, I don't want to participate. So.
That's true. Yeah, I think you make a great point about having the connections with other providers and other practitioners. And I think that's oftentimes a challenge for many of us in the kind of direct to patient care, because it's a lot. It's a big ask sometimes. But I think in some ways having that care team, much in the same way, like we are not therapists, we are not psychologists, and that in that sense that, I think in some ways it can be helpful to you and almost less burdensome to a clinician to be able to have that team that they can rely on.
Yeah. Yeah. And it could take time to establish that. And it certainly takes work. But I feel like one of the things I want to do on the next, 20, 30 years of my career is really try to start to educate the medical community more. Not only, I see my work as multidisciplinary, not only working with prosthetists and PTs, but also vascular surgeons and primary care doctors and podiatrists. I mean, this really, this kind of work is cross-disciplinary, and it needs to be. And so that's really something hopefully, I can strive to do over these next few years.
Kind of coming back to a little bit more like looking in the research context and I think kind of broader overall even, as you've kind of unpacked these things, I'm sure this has probably led to questions of why does it have to be like this? Why does this, why are these patients experiencing these kinds of things? There's a whole host of issues. That's a whole podcast unto itself. But I'm just kind of curious, are there things that are like kind of key aspects that you've thought about in terms of like how could clinicians advocate? I mean, certainly state chapters of like the American Physical Therapy Association, national, they're obviously very active in lobbying and trying to, fight for patients in many ways. Are there kind of key areas that you have seen or that you've felt have been kind of come out of like the research that you've done or things that you've seen?
Yeah, I think that the more that we do, the more we're really seeing how important, mental health is and like instrumental support for these folks. Just being married has shown, that they do a little bit better, and that's, across age ranges. Not to say that single people can't, rehab better, but there's that piece of support. Folks have family members who really want to help, but a lot of times these family members are working, during the day and are limited. And so, um, any way that we're able to connect them with maybe a potential support network, whether it's a peer support group, which aren't for everybody, but I usually try to tell people, give it a try, see what you think. And then, yeah, it can be a struggle, I think, to try to figure out, how do I get this patient support, and what kind of resources can I give them? But I think all we can do is try, reach out to colleagues, try to find out what might be available, to get either peer support or to improve some of their family support, or friend support. That's really been a big one. And that ties in with their mental health, that isolation piece you talked about.
Are there kind of any key resources or maybe even like other areas of research that, let's say if somebody wanted to learn more about this kind of area that you would point them towards? You kind of mentioned that you have kind of almost like, I'm going to say benchmark, but kind of referenced other areas of like diagnoses and populations.
Yeah, I think that anytime that I'm trying to look for information and it's not been done in the amputee population, typically the stroke population and the MS population has a lot of work that's already been done, especially the MS population with regard to like psychosocial aspects and recovery, mental health, things like that. Probably still not enough, but more work than that's been done, I think, in the amputee population. And so those tend to be the areas that I will go to. Certainly, the geriatric literature also has probably more than almost any other patient group. And so if I need some sort of support for something that I want to look at, those are typically the populations that I'll look at. I hope that answers your question.
Yeah, that's perfect.
Okay.
All right. Always my last question. Kind of going back into, this could be either like research subjects that you've had or a patient in the past. But I often think that for many of us, at least I know myself, is there are people that stick out in your mind. They're just like kind of key things that they're formative and making you a clinician that you are, or making you a researcher that you are, and have inspired you to go into the what you've done. Has there been like a particular patient or subject that you were able to kind of like identify some things and to be able to help them out that kind of made a difference for them?
Yeah, I think especially when we're talking about disparities, I feel like I've learned something from every single patient I've ever seen, which is many, many patients. But with regard, one woman sticks out in my head whenever I talk about my disparities work. And she was one of my first study participants when I first started the disparities work. And we actually had to wait to enroll her for about 3 months because she was 38 years old. She was a Black woman, and she had a right below the knee amputation. She was missing one toe on her left foot. We had to wait for a wound to heal before we could enroll her. And she came in and she just had the best attitude. And she was so happy to wait to even get into the study. And she was smart and she was organized and she had young children at home. And she was 38 and she was already amputated, below the knee on one leg, and was probably going to be below the knee on the other eventually. And I think to myself, why is that happening? Why is she so young and have these family responsibilities and have this, I think to myself, is she putting other people before her? And that was kind of the root of these studies and finding out more about why is this happening to certain people. And so she always sticks into my head. Always.
Yeah. And it drives you to pursue answers to these questions and to be able to do that. I think that's kind of almost like just a drive for any clinician that's working with a limb loss population. It's just that like there are so many factors that are going into it, so many challenging aspects beyond just Are we doing the right exercise? Is the leg fit today? It is a whole person's worth of things that are going on that affect the outcomes.
Yeah, it is.
Awesome. Well, Sheila Clemens, thanks for being here.
Oh, thank you for having me, Will.
Absolutely.
It was a pleasure.